Okay, good afternoon, everyone. My name is Ann Wong with the Illinois chapter, American Academy of Pediatrics, and I thank you for joining us for today's webinar for National Influenza Vaccination Week. Today we are joined by Dr. Angela Campbell from the Centers for Disease Control and Shally Allen from Families Fighting Flu. Before we begin, I would like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. Everyone will receive a copy of the PowerPoint slides, a link to complete the survey, and a link to the recording of the webinar by the end of business day tomorrow. If you have any questions for our speakers during the presentation, please enter them into the question box on your control panel for the webinar located on the right-hand side of your screen. Your question will be answered at the end of the presentation. I would now like to introduce Dr. Angela Campbell. Dr. Campbell is a medical officer in the Epidemiology and Prevention Branch in the Influenza Division in CDC's National Center for Immunization and Respiratory Diseases. She completed her medical degree at Vanderbilt University and trained in pediatrics and pediatric infectious diseases and completed an MPH at the University of Washington. Dr. Campbell first worked at CDC as an EIS officer, followed by several years in academic medicine in Seattle before rejoining CDC in 2013. Her current work focuses on studies of vaccine effectiveness, influenza antiviral treatment and antiviral effectiveness, pandemic preparedness, and development of CDC clinical guidance related to treatment and prevention of seasonal and novel influenza viruses. She is an adjunct associate professor of pediatrics at Emory University School of Medicine and has a professional staff appointment at Children's Healthcare of Atlanta. Please join me in welcoming Dr. Campbell. All right, Dr. Campbell, I'm going to switch the screen over to you now.
Okay, and can you hear me okay?
Yep, I can hear you.
Great.
All right, all yours now.
Okay, and you should be able to see it now also, right? Okay, let's see.
Don't see.
Let me check it one more time. Now, is it showing?
It is, but I think it's showing both of your screens.
Okay. I thought I had it all figured out how to avoid that, but let's go back to...
No big deal. Oh, there we go.
Okay. All right, best laid plans, right? Great. I think we are in business then. You can hear and you can see my slides.
Yeah.
Well, thank you, and hello, everyone. It's a pleasure to speak with you today during National Influenza Vaccination Week. I will begin with, let's see, got to make sure it advances. There we go, the requisite disclosure slide, and say that I have no financial disclosures, and I will discuss off-label use of influenza antivirals. That's because these drugs are FDA approved only for use in treatment of acute uncomplicated influenza within 2 days of illness onset, and I will discuss uses outside of that indication. So I will begin by describing and interpreting the various indicators of seasonal flu activity that are reported weekly by the CDC. I will then go over recent data for flu vaccine effectiveness as well as vaccination coverage, all with sort of a focus on children and pediatric data. I will discuss the CDC Advisory Committee for Immunization Practices, or ACIP, and AAP recommendations for the 2017-18 season. And then I'll briefly review recommendations regarding antiviral use in children. So I'll show you data for these bullets in the next few slides, but just a quick summary of last season is that influenza activity peaked in mid-February. That was nationally, although this did vary, and for example, the western regions peaked in late December, so it can vary regionally. Last season, influenza A H3N2 viruses predominated overall, but similar to many seasons, we did see that influenza B viruses were reported more frequently in the latter part of the season, from about late March until early July. The majority of circulating viruses last year were similar to those contained in the vaccine, and activity was moderate with severity indicators within range of what has been observed during previous H3N2 predominant seasons. So you may all be familiar with FluView, but just wanted to highlight this. Each week at CDC, our surveillance team analyzes the data that is reported from various sources and then summarizes it and makes these data publicly available in both a static report called FluView and an interactive online application called FluView Interactive. And both are updated each Friday and are found on our website at this link. So all of these next few slides are data from FluView for last year and the beginning of this season. So this figure shows the percentage of people who have seen their healthcare provider for influenza-like illness, or ILI, with season week on the x-axis. And so this thin blue line marks where 2016 ends with week 52. And 4 recent seasons are shown, and you can see how much the seasons vary really in so many ways, in onset, peak, duration, and intensity. So 13-14 and 14-15 both peaked in December, while 15-16 here in orange was a very late season with relatively low activity compared to the others. And then last year, the bold blue line peaked, that season peaked in February. And so this red line shows you what is happening so far in this current season. And you can see that activity for the past about 4 weeks has been increasing, so that most recently, this is data for week 47 that ended November 25th, ILI activity was just above the national baseline, which is 2.2%, and this point here is 2.25%. So this Friday will be updated with week 48 data. Sorry, I forgot to show the circle when I talked about this season, so there you go. So this figure shows the results of tests performed by public health laboratories and reported to CDC for last season and the current season. And red represents H3N2, which predominated, like I said, last year. And then here's this green virus peak. It was mostly B. Yamagata lineage later last season. And so far this season, with this inset here blown up to show you what we're seeing, it's again predominantly H3N2 viruses, although we are seeing some B as well as some H1N1s so far this year as well. And even though it's predominantly H3N2, at this point we still say it's too early to predict what type or subtype will predominate, because we have seen this change when we start to get more viruses. This slide shows you cumulative rates of laboratory-confirmed influenza-associated hospitalization. So it's rates per 100,000 population, and it's by age group, and this is data for last season, the 16-17 season. This comes from CDC's Influenza Hospitalization Surveillance Network, or FluSurvNet, and that's a population-based network for hospitalizations in both children and adults. So clearly, as is typical, and especially in seasons when H3N2 viruses predominate, the highest rate of hospitalization was among adults 65 years and older. And that was at about 275 hospitalizations per 100,000. This was followed by adults 50 to 64 years, then children 0 to 4 years, young adults 18 to 49, and 5 to 17-year-olds. And these last two groups tend to be kind of consistently the ones with the lowest hospitalization rates. But I always want to point out that about 50% of the children hospitalized with influenza had underlying medical conditions, which really means that 50% did not. So half of these kids who are hospitalized, and this is pretty consistent every year, were previously healthy children. Also, just want to show you what we're seeing for this year. The cumulative hospitalization rates are still quite low, as you might expect, since we're only in the first few weeks of flu activity. You can see that hospitalizations have begun, and if you could see this axis over here, it only goes up to about 8. And so the adults 65 and over lead, but it's still a fairly low rate at about 7 people per 100,000. So moving on, in addition to lab-confirmed hospitalizations, we also look at mortality. And this is pneumonia and influenza mortality that comes from the National Center for Health Statistics. This slide shows data for the past 4 seasons, with the beginning of the current season starting since October 1st, sorry, over here in the blue box. So this tail end is all we have for the current season. The red line is the percent of all deaths occurring each week that have pneumonia or influenza listed anywhere on the death certificate. And the black lines represent the seasonal baseline and the epidemic threshold. So you can see we're really not over the threshold for the season yet, but severity indicators such as hospitalizations and deaths tend to lag behind the ILI indicator. And as you all know, unfortunately, we do see influenza-associated pediatric deaths every year. So this figure shows histograms for the last 3 seasons with a total of 148, 92, and 110 deaths in those seasons. And thus far this season, these actually went in the 16-17, but these last little 5 over here represent 5 pediatric deaths that have occurred so far this season. And from what I know, 2 of those were associated with H1N1, 2 H3N2, and 1 that is A, not yet typed. Also just wanted to comment that of the pediatric deaths, in general, about 75% of those children have not been vaccinated. So here's a map showing current geographic influenza activity as reported by state and territorial epidemiologists. This is really an indicator of spread and not severity, but the dark brown shows you where widespread activity has been reported by 4 states. It's Georgia, Louisiana, Massachusetts, and Oklahoma. And then regional activity has been reported by Guam and 10 states, and then the others have local, sporadic, or none at this point. So stay tuned to FluView and see what this next few weeks bring. I think again we really aren't able to predict, but we are starting to see fairly widespread activity. So now I want to move on and discuss recent vaccine effectiveness estimates for the last couple of years, and then review the vaccine recommendations for the 2017-18 season. I just want to make sure everyone is up to speed on these. So I want to start by introducing the U.S. Flu Vaccine Effectiveness Network, or we call it our U.S. Flu VE network. There are 5 sites that participate with CDC. It's a network that enrolls outpatient participants 6 months of age or older who present with acute respiratory illness with cough. And this network uses a test-negative study design approach to estimate effectiveness of flu vaccine. And this is a pretty standard approach for these types of observational studies, in which the case control status among participants who present with respiratory illness is assigned based on their flu testing results. So influenza positive persons are cases and negative persons are controls. And then the VE is calculated as 1 minus the odds ratio times 100%. So again, fairly standard methods for VE in large observational studies like this. This slide is from the June ACIP meeting, so these are considered the interim VE estimates as of June. The final paper is close to completion, and the numbers have changed just a tiny bit since then, and I'll kind of mention that as I go along. But let me orient you to this table format. The influenza positive cases and negative controls are shown over here on this half of the table, with the number vaccinated over total, and then the percent. And then the section on the right shows the VE estimates with 95% confidence intervals, first the crude and then the adjusted estimates. The final models were adjusted for the covariates noted in the footnote. And so overall, for people of all ages vaccinated against any flu virus, you can see in the top row that I wanted to show over here too, 43% of the positive cases were vaccinated and 54% of the controls, with an adjusted VE point estimate of 42%. And my understanding is that the final estimate that will be published is 39%, so a little bit lower when all the final data came in. For children, the VE for the 6-month to 8-year age group was 61%, and for 9 to 17-year-olds was 35%, both of which were statistically significant with confidence intervals that did not cross 0. And then I just wanted to show you the H3 specifics. So this looks almost identical to the previous slide, but this is against H3N2 only, whereas the last slide was against all flu. These are the specific numbers. All ages, there was an adjusted VE of 34%. And then for children, the youngest age group, 51%, and the 9 to 17-year-olds, 31%. And again, those have moved only a tiny bit. The final adjusted H3 estimate for all ages is 32%. And for the children, it's 48 and 33. So very similar to the interim estimates that were shown at the ACIP meeting. So I just wanted to sort of take a little break from our CDC data and show you the results of a recent meta-analysis that was performed. And this pooled estimates from vaccine effectiveness studies that use the test-negative design in order to estimate VE by type and subtype. And they used data from 2007 through 2015. And this analysis found that the pooled VE for H3N2 was also a little lower than for the other viruses, similar to what we've seen. So it was 33%, lower than that for type B, which was 54%, and the H1N1 PDM09 virus of 61%. And so this pattern for a little lower VE for H3N2 also was similar when you looked only at the pediatric age groups. So I've shown you the 16-17 flu network data, the meta-analysis, and then I just want to go back one prior season. This was an H1N1 predominant season, but it helps sort of remind us all about the recommendations concerning LAIV, so I wanted to share this with you. So these estimates are published, and this figure focuses on the adjusted estimates in children. Just to orient you, when the point estimate and the confidence intervals fall completely to the right of 0, that means the vaccine was effective. And if it crosses this line, that means that it was not. So you can see that this was the case for VE overall. There was a 52% vaccine effectiveness pooled estimate, and also when stratified by, when stratified by H1N1 and B, there was effectiveness. So I just kind of wanted to show how we take this number of a 52% overall VE and translate it into terms that we can communicate to the public and that may be more easily understood. Our models were able to estimate that a VE of 52% would translate to an estimated 5 million illnesses and 2.5 million medical visits prevented and 71,000 hospitalizations prevented. So we don't have those numbers yet for 16-17, which is why I wanted to kind of go back one season and show you how we can use our VE estimates to estimate averted burden of various types of illnesses. And then just going back to this, this data from 15-16, I want to show you the results by vaccine type. So inactivated or the flu shot versus live attenuated influenza vaccine, which was flu mist. So focusing just on the inactivated influenza vaccine, or IIV, vaccination was effective. Again, you can see over here on the right, against influenza caused by any virus, it was 60%, 63% for H1N1, and 54% for influenza B virus. However, among those who received LAIV, again, flu mist, the effectiveness of the vaccine in this group was not significant for prevention of flu overall or of H1N1 or B. So it was these findings, as well as data that I'm not showing you today from 2 prior seasons, that were presented to ACIP in June of 2016. And you likely remember that the ACIP voted to revise the flu vaccine recommendations for the 16-17 season. And the wording was, in light of concerns regarding low effectiveness against influenza A H1N1 PDM09 in the United States during the 13-14 and 15-16 seasons. For the 16-17 season, ACIP makes the interim recommendation that live attenuated flu vaccine, or LAIV4, should not be used. I guess I should just note the reason the 14-15 season was not mentioned is that that was the year we had a drifted H3N2 virus, and most all of the vaccines showed low VE. So hopefully that reminds you why LAIV has the recommendation that it has, and I'll show you this when I get to the current recs, but this was carried over for the 17-18 season as well. One other important publication from 2017 I wanted to share is this paper showing the effectiveness of flu vaccination against pediatric deaths. So there were 358 flu-associated deaths among children 6 months to 17 years, and 26% of those received vaccine before illness onset, whereas the vaccination coverage in the comparative survey cohorts was 48%. So this led to a calculated overall VE against death of 65%. When they looked just at kids with underlying high-risk medical conditions, 31% were vaccinated, still really low. These are the kids that need to be protected. And among those kids, the VE was 51%, and among those without high risk, 65%. So this paper was the first of its type to really show that the flu vaccine could prevent death from a death associated with influenza in children. So next, I wanted to show you data on influenza vaccination coverage for the past season and then the years prior. And this is because, as you probably know, there was concern that coverage might decrease among children because of the recommendation not to use flu mist in the 16-17 season. But you can see in the top line that nationally, parent-reported flu vaccination coverage among children really didn't change here in the 16-17 season at 59% compared to 59.3% in 15-16. And then if you break out the children by age group, first of all, vaccination coverage decreases with increasing age, and I think that's not surprising. So the young ones, the top line, 6 months to 4 years, had a coverage of 70% in 16-17. The 5 to 12-year age group had a coverage of 59.9%, and then 13 to 7 years tend to not have as many doctor's appointments for all sorts of reasons, have the lowest coverage of 48.8%. But interestingly here, among the children 5 to 12 years of age, coverage in the last 16-17 season was 1.9 percentage points lower than the 15-16 season. But in these older kids, the 13 to 17-year-olds, coverage was 2 points higher. And if anything, well, I don't know that we could have predicted, but you might have thought that it was the older ones that wouldn't have wanted to get a vaccine and might have preferred flu mist. But overall, I think these kind of canceled each other out, and the bottom line, it was overall very reassuring that the lack of LAIV did not lead to big changes in vaccination coverage. So next, I'm just going to review highlights from the 2017-18 ACIP statement. The core recommendation remains exactly the same, and it's been this way since the 2010-11 season, that annual flu vaccination is recommended for all persons aged 6 months who do not have 6 months or older who don't have contraindications. And this aligns right up with the American Academy of Pediatric recommendations as well. I'm not going to show both documents throughout, but I just wanted to mention that. And so what hasn't changed in the current statement is, again, the extension of the recommendation from 16-17 that LAIV not be used has carried over. For children 6 months through 8 years, there are, again, some children that require 2 doses. These are required during the first season of vaccination. And basically, this is the simple algorithm that can be followed where the question, has the child received at least 2 total doses of flu vaccine before July 1st, 2017, should be answered. And this doesn't have to be in the same season. It can be consecutive. If they have received at least 2 total doses, then they only need 1 dose in the current season. But if not, they should have 2 doses given at least 4 weeks apart. And then the last thing that is similar to the 16-17 ACIP statement is that egg allergic persons can receive any licensed recommended vaccine that is age appropriate. So an allergy such as hives does not preclude from receiving any flu vaccine. There is a caveat that if there's a history of severe allergic reaction to egg, like anaphylaxis or something other than hives, that vaccine administration can still be given, but should be supervised by a healthcare provider who's able to recognize and manage allergic conditions. The vaccine composition for this year is changed only in one component from the last year, and that is that the H1N1 virus was updated to this Michigan strain. And and then this summarizes new licensures and labeling changes, particularly relevant to children for the current season. So the first is that Afluria quadrivalent has now been licensed down to 5 years and up. It was initially licensed for age 18 years and older. There remains availability of Afluria trivalent also, and this previously was recommended only for age 9 and up, and now is available, licensed, and recommended for 5 years and up. So the reason for this previous recommendation was that there was an increased risk of febrile seizures in Australia during the 2010 season. And in February of 2017, the ACIP reviewed data showing that the putative cause was that there were residual lipid RNA complexes after the vaccine viruses had been split. And they have since changed the formulation of this vaccine, and the reactogenicity has been diminished. The increased risk of febrile seizures is no longer deemed to be as much of a concern, and therefore it's now recommended down to age 5. And then lastly, Flu-Laval quadrivalent, previously licensed for age 3 and older, is now licensed down to age 6 months. And so this is really important because this is one of 2 vaccine products approved for children 6 to 35 months of age, that really young age group. So I want to say a little more about Flu-Laval quadrivalent. The dose volume is 0.5 ml, which is the same volume that any other age person receives, whereas previously 6 to 35-month-olds were recommended to receive a smaller vaccine dose of 0.25 ml. And this was based on increased reactogenicity noted in trials using whole virus vaccines. These are older trials. However, newer split virus vaccines that are currently available are less reactogenic in this age group, and there have been recent studies comparing Flu-Laval quad, the 0.5 ml, to 0.25 ml Fluzone quadrivalent, and have shown that safety is comparable. So Fluzone quadrivalent is the other product licensed for this age group, and that's 0.25 ml, so care has to be given to give the appropriate product at the recommended dose. And then also, I think it's important to note that dose volume is distinct from number of doses needed. So a child 6 months through 8 years who needs 2 doses, as we just discussed, if they get 0.5 ml for their first dose, that doesn't mean they've had sort of 2 doses. That's just 1 dose of Flu-Laval quadrivalent, and then they still need a second dose at least 4 or more weeks later. So I want to end my section of this webinar talking about antivirals, because we always recommend flu vaccine as our first line of defense. It really is, but if and when vaccination fails, which it can, we really feel that antivirals are an important adjunct to flu vaccine. And so there are 3 FDA-approved neuraminidase inhibitors that are recommended for use. The first is oral oseltamivir, or Tamiflu, but there's also a generic formulation available and has been since December of 2016. That's when the capsules became available. And then this year, September 2017, pediatric suspension, generic suspension was approved. And oseltamivir is approved for treatment of children aged 14 days and above. That's the FDA approval indication. However, both CDC and the AAP recommend it for all ages, even down to birth, if needed, because there are some subsequent safety data that wasn't in the FDA's initial licensing. The second neuraminidase inhibitor that is recommended is inhaled zanamivir. It's called Relenza. It's given through this disc haler, so it does have a different mechanism of delivery. And that, because of that, it's approved for treatment of kids age 7 and above, because it takes some coordination to be able to use the disc haler and breathe it in as you need to get the inhalation dose. And then the last neuraminidase inhibitor is intravenous peramivir. This is an IV medication that is approved for treatment down to age 2 as of this year. And so you could imagine this might be used in perhaps a dehydrated patient in an ER because this is, I guess I don't have this on the slide, but this is a 1-dose medication. So they don't have to take it for 5 days, which is the duration for the other 2. So these are our treatment recommendations. We actually sort of focus them on certain population groups. CDC recommends treatment as early as possible for any patient with suspected or confirmed flu who is hospitalized or who has severe, complicated, or progressive illness, or who is at high risk for influenza complications. For everyone else, previously healthy symptomatic outpatients not at high risk with confirmed or suspected flu, antiviral treatment can still be considered on the basis of clinical judgment, especially if it can be given early in the course of illness within 48 hours, because that's when it's really been shown to have benefit in shortening the duration of illness. So I just wanted to show what persons at high risk for influenza complications, what that means. This is sort of the list, and this is also the list that really ought to be vaccinated. So children less than 2, adults 65 and older, pregnant and postpartum women, American Indians, Alaska Natives, obese, residents of long-term care facilities, immunosuppressed patients, children on long-term aspirin therapy, or people with various underlying medical conditions. So that's just a reminder of that list. And then moving on, I have one slide that summarizes a lot of data, but I just wanted to try to say why we've focused our antiviral recommendations as we do. So all of the trials that led to licensure of antivirals were randomized clinical trials performed in people with uncomplicated influenza, so outpatients. And these trials showed that early treatment shortened the duration of fever and illness symptoms by about a day to a day and a half when given within 2 days or 48 hours of illness onset. So our focus of our treatment guidance really isn't on these people. It's on preventing severe outcomes, those who are hospitalized or at the highest risk of complications. And for those people, we don't have randomized controlled trials. We have to base our recommendation on observational studies and meta-analyses that have been performed of these studies. And so there are studies that have shown treatment can reduce complications such as otitis media in children and pneumonia requiring antibiotics in adults. And there are other studies and a large meta-analysis that has shown early treatment of hospitalized patients can be associated with a reduction in death and also shortened length of stay in children and older adults. So that's one brief packed data slide to say why we recommend what we do. I want to say that if treatment is given, it really should be started as soon as possible after illness onset. The earlier, the better the outcomes. We know clinical benefit is greatest if it can be started within 48 hours of symptom onset, but we also recommend that it not be delayed at all while waiting to confirm laboratory testing. If a person meets indications for treatment or a clinician feels should be treated, the treatment should not be delayed while waiting for a test result. And importantly, a rapid influenza antigen diagnostic test, an antigen-based rapid test, is not always very sensitive, and a negative test doesn't exclude a diagnosis of flu. So clinical judgment is very important in this case. There are a couple of examples, and there are some people for whom we think antiviral treatment after 48 hours may still be beneficial. Primarily, there are a number of observational studies in hospitalized patients that suggest treatment might still be beneficial when given 4 or 5 days after the onset of symptoms. There's some data in pregnant women that have shown treatment provided benefit when started 3 to 4 days after onset. And there's one randomized trial in children with uncomplicated flu who showed that when they still had fever at 72 hours, oseltamivir did provide some clinical benefit, even out to 72 hours from illness onset. So I've just taken you kind of through a whirlwind, but in summary, I want to end again with the fact that annual flu vaccination is really the best way to protect against this potentially serious illness. I've tried to show you that it certainly can cause morbidity and even death, even in children, unfortunately. Flu activity is usually highest December through February, so it's certainly not too late yet. And we always say as long as influenza viruses are circulating, it's not too late to vaccinate. And lastly, that antivirals are an important second line of defense. We often have this take 3 message that says get your flu vaccine, wash your hands, and take antivirals if prescribed by your doctor. I just wanted to highlight this, and there's a number of other National Influenza Vaccination Week resources available at this link on the CDC website that could be used well beyond this current week, obviously. And then this is a list of other resources, particularly about our surveillance systems, the Immunization Services webpage on coverage. My understanding is that the vaccination coverage estimates for the current season should be released within the next week, I think, on that webpage. And then for professionals, there's some home pages for vaccination. The ACIP recommendations document our antiviral homepage. And there's even some information for children, and there's this great little coloring book that was created by CDC and endorsed by the AAP about Ready Wrigley preparing for flu season. And then this awesome graphic is, again, just another example of what's available at the NIVW Resource Center website. So I will end my section of the call, and my understanding is I'll take questions after our next presenter near the end. So thank you so much.
Okay, thank you so much for that presentation, Dr. Campbell. We're now going to move on to the second part of the presentation, and that's going to be Shelly Ann, who's going to be sharing her family's story. So Shelly, you should be able to speak right now, and then I'm going to go ahead and pull up the screen for you.
Okay, great. Can you hear me?
Yes, I can hear you.
Perfect. Good afternoon. I first would like to say that I have no relevant financial relationship with the manufacturers of any commercial products and or provider of a commercial services discussed within the CME activity. I do not intend to discuss unapproved or investigative of a commercial product or device in my presentation. To start off, again, my name is Shelly Allen, and I am a member of Families Fighting Flu. I am also the mother of a 19-year-old daughter who was stricken with a horrible illness caused by influenza at the age of 12. We are fortunate that our Maddie had a better outcome than many other children who have had this disease. Yes, influenza is a disease, and it takes lives. It breaks my heart to see so much sadness from flu deaths, but we are determined to tell Maddie's story so that people will learn from us. We truly believe in the cause and want to make a difference. If one person learns from our story, then we have accomplished something. However, I hope so many more people will listen, learn, and vaccinate themselves and their loved ones against the flu. Our story actually begins on February 21st of 2011. And prior to this, Maddie had always been a very healthy, active child. She lived, breathed, and slept sports. If she didn't have a basketball in her hands, then she had a soccer ball at her feet. She was a high honor roll student and loved school and hardly missed a day. Maddie loved spending time with family and hanging out with friends. In February, 7th grade basketball had just finished up, and Maddie was already in gear for indoor soccer and getting ready for her travel soccer in the spring. On February 18th, Maddie went to a friend's birthday party, but a couple of hours later, she texted me and said she thought she better come home. She wasn't feeling well. That was Friday, and over the weekend, she ran fevers and had a bad cough. Nothing I felt was too concerning, though. We just thought it was a bad cold or a run-of-the-mill flu, so I continued to give her over-the-counter medicine to break the fever. On Sunday night, she was very uncomfortable and her back started hurting. So my husband and I decided we would take her to her pediatrician on Monday morning. Throughout the night, she did not sleep well, and we noticed a slight change in her breathing. The next morning, we waited for the doctor's office to open so we could get her in. I suggested that she take a shower because I thought it may help. She asked me to help her because she did not have the strength to do it herself. I remember closing the curtain to get her a towel, but when I opened the curtain back up, I knew something was seriously wrong. Maddie went very pale, almost yellowish, and her eyes were dark and sunken in, and her lips were blue. It was 7:30 a.m. on February 21st, and we immediately rushed her to our local hospital. Once there, they placed her on oxygen and did x-rays. They knew she had double pneumonia. My husband and I talked at that time, and we decided she needed to be transferred to a bigger hospital about 30 minutes away. So my husband rode with Maddie in the ambulance. By the time I got to the hospital, Maddie was in respiratory distress, and the doctor needed to intubate her. I went into Maddie's room and explained to her that she had to be put to sleep so the doctors could give her strong medicine to make her better. I didn't know what else to say, but I just knew I needed to be strong for her and not show her how scared I was. However, she knew, and I could see it in her eyes. The tears came rolling down my face. Her last words to me were, "Don't cry, Mom. I love you." Those were the last words I heard from her for the next 5 weeks. Things went fast, and her health declined even faster. Around 8 or 9 p.m. on that same day, the doctor came into the waiting room. By this time, the room was filled with all of Maddie's loved ones, basketball coach, and even her best friend. And they asked to talk to me and my husband. I knew in my heart it was not the talk I wanted to hear. She told us that there was nothing more that she could do here at this hospital, that she had called in St. Louis Children's Hospital. She said Maddie needed to be placed on a special machine and that was the nearest hospital that specialized in ECMO. By the time the flight team from St. Louis Children's Hospital got to Maddie's room in Springfield, she had been placed on the oscillator and had 14 different IVs. They worked 3 hours to get her transferred to their bed. The trip took 35 minutes, and they had to handbag her the whole time. When they got there, Maddie went directly into surgery to be placed on ECMO. I was not able to ride in the helicopter with Maddie, so my sister and my mother drove my husband and me to the hospital. It was the longest ride ever. Every time my husband's phone rang, I just prayed it was not the flight team telling us she did not make it. We finally arrived at the hospital, and I could not walk fast enough to get to the PICU. I just wanted to see my daughter and make sure everything was okay. I walked into a cold, dim room, and they said Maddie was in. I was in complete and utter shock. First, there were so many machines hooked up to her that the only spot I could touch that did not have a tube hooked up was her feet. I began to sob uncontrollably because the body that was lying in the bed did not look like my beautiful daughter. They had to put so much fluid in her that it made her face so swollen and all her freckles disappeared. She walked into the hospital at 95 pounds, and now I was looking at a 150-pound girl. As I was getting the reality check of what was truly going on, my husband and family were listening to the words of Maddie's doctors saying it was more than likely she would pass and not make it throughout the day. It took many cultures, but they were finally able to diagnose her with influenza B and MRSA pneumonia. Maddie had many setbacks, but eventually was able to come off ECMO after being on it for 2 weeks. That was probably the first time I truly took a deep breath. I felt like I was on pins and needles for those 2 weeks and couldn't breathe because it may change things. She still had a long way to go, and we were warned that there were still bad days ahead of us. It took another 3 weeks before Maddie was able to be removed off the ventilator and dialysis. Maddie had several obstacles, but with the faith of God, prayers, our wonderful doctors, nurses, and Maddie's incredible determination to fight, she was able to get better. Maddie only had a 1% chance of survival, but after 93 days in the hospital, Maddie was released and we took her home. In February, we are about ready to hit our 7-year anniversary of her illness. Maddie still suffers from a chronic cough and lung disease. She is also prone to pneumonia and recently just had to spend 5 days at St. Louis Children's Hospital. Before that, her last hospital stay was 4 years ago. We are truly blessed and amazed how far she has come. Today, Maddie is in her 2nd year of college at Hannibal LaGrange University on a soccer scholarship. Don't worry, she plays goalie. She had an amazing season and ranked 5th in NAIA, which is the division they play in, and that was missing 5 games during the season due to pneumonia. She still gets exceptional grades and participates in many volunteer programs. She's a trooper, and when people ask her if it stinks to be sick at times, she says the outcome could have been a lot worse. She tells them she just takes it one day at a time and makes the best of it. She says, I appreciate life and everything I am given. She's such a wise young lady. I tell people that if her insides looked as good as her outside, she'd be in a great place. So that year, Maddie got sick. We were not vaccinated against the flu. I put it on my to-do list, but never got to it. We got too busy with work, school, sports, and our lives. However, that one mistake almost cost my daughter's life. My only child, my greatest gift. I live with that guilt still today and will for the rest of my life. I'm her mother. I'm her protector. And unfortunately, I failed that year. Maddie had been vaccinated all the other years, but that year it just fell to the end of my to-do list. It's taken me several years to come to terms with my guilt, and that is why I tell our Maddie's story. So no other parent has to have a story like ours. We now make sure we are the first on the doctor's list to be vaccinated. We encourage everyone that is around Maddie on a regular basis to be vaccinated too. Before Maddie was sick, we did not take the flu seriously. We thought the flu meant that you were sick for a few days, but you got better. However, that was not the case for Maddie. My hope is that people will listen to Maddie's story, learn from it, educate themselves and others about this very serious yet preventable disease. The best advice I can share with you all today is to get vaccinated against the flu this season and every year. It's our best defense. I thank you for allowing me to share a short version of Maddie's story, and for more information, please feel free to check out familiesfightingflu.org.
Okay, thank you so much, Shelley, for that really engaging and powerful story. So we're now going to move on into the question and answer portion of our presentation today. And I just wanted to remind everyone that you should be able to find the question box on the right-hand side of your control panel. I'm going to go ahead and finish up really quickly with closing out the webinar while I wait for people to enter in any questions that they might have. So I just want to let everyone know that you will be receiving a copy of the PowerPoint slides, a link to complete the survey and evaluation, and a link to the recording of the webinar by end of business day tomorrow. Everyone must complete, oops, don't know what happened there. Sorry about that. Okay, so everyone must complete their evaluation by December 21st, 2017. After this date, the evaluation will be closed and you're no longer going to be allowed to fill out the evaluation or receive CME credit. And then 2 weeks after that, on January 4th, you should receive your certificate for the continuing education. So let me see if we have any questions. So it doesn't look like we do have any questions. So I just want to say, Dr. Campbell, is there anything else you want to share to wrap it up at all?
Thank you, Shelley, so much for sharing that. I think that we can talk about our data and our papers and our studies, and it's powerful, but it's not as powerful as hearing it from you. So my voice is almost shaky because I was actually very moved by your story. I think that it really drives home. One thing that I was sort of thinking about is you mentioned that your daughter had influenza B, and one thing that people are talking about quite a bit for us is you probably all noticed that the H3 vaccine effectiveness numbers are a little lower than the H1 and the B, and there's probably a couple of reasons for that. The H3 viruses probably undergo more frequent genetic changes than the others, and therefore require more updates to the vaccine viruses. And the other thing that is somewhat related to that is that the H3 viruses in the vaccines can acquire some genetic changes during the process of making egg-grown vaccine viruses, perhaps with a greater impact than H1 or B. But one thing that I hope for all of you that you recognize is that even 30 to 40% vaccine effectiveness is so much better than none, and we can still prevent millions of illnesses and thousands of hospitalizations like the one you just heard about. And also, there are other viruses other than H3. That was a powerful story of a flu B hospitalization. We also see quite a few hospitalizations in children with H1N1, and the vaccine does provide protection against H3. So I think, when people are asking you as providers about the vaccine, there are a number of benefits to it. There's a number of different flu viruses circulating, and some benefit is definitely better than no vaccination at all. And it couldn't have been said more powerfully than Shelley just did. So, but that's one kind of question that we get, and so thought I would share that information. I don't know, is there anything else from anyone?
Yeah, so looks like we have gotten a couple questions in, and one of them is, do you recommend treatment of pregnant women who were exposed to flu?
Okay, so that's really getting at chemoprophylaxis, which I didn't talk about in my talk at all today. It's true. I would refer you to the antiviral clinician page on our website as well. I will say in general, we don't recommend chemoprophylaxis very broadly. The sort of one situation where we always include it as a part of our recommendations is in the setting of an institutional outbreak, where it's one very important component to getting control of an outbreak. In individualized cases like that, we don't have an across-the-board recommendation that pregnant women should receive chemoprophylaxis if exposed to flu. It's certainly something that a clinician could consider. I think there are certain things to take into account, such as the timing of the exposure. We always are try to be very clear in emphasizing that if you're going to give chemoprophylaxis, it needs to be within 48 hours of the exposure. And that's really because we don't want someone to be given a chemoprophylaxis dose, which is a once daily dose, whereas treatment is twice daily. We don't want to be giving once daily dosing to someone who may actually already have early infection that has developed. And so if it can't be given within 48 hours, it's best to wait. And often for a lot of situations, including the one that's being described, we often recommend that close following and watching and giving early antiviral treatment if symptoms develop is a very reasonable approach to someone such as a pregnant woman or someone else who may be at high risk who's been exposed to flu.
Okay, and another question that we got was, is there a specific screening checklist that we should use prior to administering a flu vaccine other than the general screening checklist that is used for other vaccines?
No, I don't believe there is. Gosh, you're asking a very basic administration question, and I think if it's there's really, especially with the removal of the egg allergy precautions, with the exception of severe egg allergy, I think the basic supply, basically the main contraindications are if there's a history of an allergy to a component of the vaccine itself, and I would just recommend using the vaccine information sheets that come for flu. There's nothing special or in particular that, there's no special checklist, no.
Okay, and then the last question that we have is, someone heard that there's only 10% of strains in this year's vaccine. Is that true?
I'm not quite sure what that question means, but this year's vaccine, I showed the components. I went kind of quickly over that slide, but as in all years, it contains an H3N2 vaccine, an H1N1 vaccine. The trivalent contains one B component, and the quadrivalent contains two. If you look at FluView, the data show so far that there's no evidence that really any antigenic drift has occurred when comparing the vaccine viruses to the circulating viruses, and it looks like most of the vaccine strains show good similarity to the circulating viruses. So I'm not sure what the 10% refers to be honest, but so far we're seeing similar viruses to what we've seen in the past, and the vaccine viruses appear to be antigenically similar.
Okay, I think that about covers it. So I just wanted to thank you specifically, Dr. Campbell, and also Shelley. You guys both gave really good presentations. I think they complemented each other really well because on one side, we had all the data-driven information, but as you said earlier, Dr. Campbell, there's nothing quite like a very personal story that kind of convinces people why the flu vaccine is so important. So I just wanted to thank you both, and also to all of our participants for joining us for ICAP's last webinar of the year, actually. So this concludes our 2017 Immunization Best Practices webinar series, and then we'll start back up again in 2018 for new immunization webinars. So thanks again, ladies, and thanks to everyone else who participated.
Thank you.
Thanks.
Thank you.